tracing is nothing but it is based on the Snell's law, and it also has the laser beam of light which enters the eye, and the exact location of the beam is placed on the retina, and it takes into consideration the optical aberrations from the cornea and the topmost layer of the cornea, which is the epithelium, and then it goes from every part of the eye right towards the retina. There's a backscatter, and that's how it measures all the aberrations, and that's how it takes into account all the optical elements in the eye. So hence, it helps into a customized ablation profile for every eye, for every patient, for every this thing. And so one of the ray tracing technologies which is right there for us to use is the Wavelight Plus, which has a companion diagnostic, which is the InnoVise Sight Map. And how it works is it has the Hartmann-Shack aberrometer, which looks at the whole eye wavefront data. It takes also into consideration the Scheimpflug tomographer data from the front and back corneal surface measurements, and it takes into consideration the laser interferometry A-scan, which gives you the exact position of the refractive interfaces of the eye. And combining all of these three devices into one is what the InnoVise Sight Map is. And as I had mentioned, that it takes into consideration the aberrations from every part of the eye. It's a combination of all of these things. You also have to enter the manifest refraction, and then it calculates the virtual 3D digital model of the eye. And the entire planning is based on artificial intelligence-driven surfaces, and the front surface ablation is calculated to focus the light rays on the fovea. So that is how the aberration is planned. Now, how does this InnoVise Sight Map diagnostic tool works? It collects the entire diagnostic data, including the patient data, and then the analysis happens based on the software processing. Then it creates a detailed eye model, which is like a 3D model, which has all the information, and that's how it calculates your ray tracing aberrations and the model light rays through the eye to help us have the perfect calculations for the aberrations based on each of this value. Now, how is this different? How is InnoVise different from the other platform is that it is artificial intelligence platform for laser vision correction. It also includes the ray tracing algorithm to measure the ablation profile for every individual eye. It considers your post-op epithelial remodeling also and the expected biomechanical changes into this, and helps us with the diffraction which is going to be treated. And the treatment is based on a model eye for each case, and it's not on the normative database, or it's not on the nomogram based on your previous calculations. So we've been doing, I kind of skipped the workflow of how to measure each of the stepwise measurements and to calculate, because I thought that my previous speakers are going to be talking about it. So from the Indian perspective, we have for now commercially available machine. We have treated 116 eyes, and we have 6-month post-op values. And you can see here is that 72% of the eyes in InnoVise achieved more than 20/20 vision, while as Contura, which is a topo-guided treatment from Alcon itself, achieved 19% of the patients who were more than 20/20. When it comes to coefficient of determination, also InnoVise had 0.99, whereas Contura was 0.96. So the InnoVise eyes did, or the Wavelight Plus eyes did little better in comparison to Contura, which is a topo-guided LASIK. And InnoVise, Wavelight Plus is nothing but a ray tracing LASIK. When it comes to gain in line or change in your lines, in InnoVise, 31% showed no change. However, 67.3% of the patients showed gain in one line or more, whereas in Contura, only 17.2% showed gain in one line. This is a contralateral eye study. So one eye was operated on Wavelight Plus, which is based on the InnoVise, and the second eye was the other eye was Contura, which is the topo-guided LASIK. And also when it comes to the spherical equivalent, InnoVise did perform much better compared to that of Contura. Now, why are we looking at customized lasers? Are customized lasers necessary in today's era, or do we need to look at something else? Like you have wavefront optimized where your patients have 20/20 vision, but sometimes they don't have very good quality of vision. Then you have topogetic treatment, which did, or contour, which did improve your outcomes, but still there were some challenges on calculations. That's why we need probably a customized laser, where this, I'll just give you one example before I finish. This was one patient where everything looks fine, but the refraction, what he accepted was only minus 3.25 dioptric sphere, and the left eye had only spherical 3.5. Patient did not have any cylinders. This all looks normal. You can see a little bit of anterior elevation, but otherwise the topography fairly looks normal. Now, if you look at his epithelial map, you can see that there is some amount of hyperplasia present in the center of the cornea for the right eye, and the left eye also. The epithelium is a little bit on the thicker side. The usual value would be 55, but here you have 65. So we went ahead and looked at epithelial aberrations, because aberration is not just from your cornea for the eye. Epithelial also has some amount of aberrations. And if you see here, the right eye, where the patient is not accepting any cylinder, the epithelial has minus 0.93 cylinder in the right eye, and the left eye has minus 1.47. Now the epithelial has aberration. Why is the patient not accepting it? It's because it's just the accommodation, and he's ignoring the right aberrations, and that's why probably his quality of vision is not right. Now, the InnoVise, which is the site map, what we use for Wavelight Plus, we wanted to see that there is an epithelial aberration. Why is the patient not accepting it? So we did the diagnostics for Wavelight Plus, and if you can see here, this patient has minus 0.7 in the right eye and minus 0.5 in the left eye as an epithelial aberration, as an aberration in the Wavelight Plus as well. So Wavelight Plus, which is the ray tracing technology, which takes into consideration all the aberrations from the epithelium right up to the retina, it is picking up. So that means if I just go ahead and do a wavefront optimized treatment for this patient, it's not going to help me. I need to do something more customized for this patient, which will probably help the patient have a better quality of vision. So we went ahead and did the Wavelight Plus for this patient, and we did correct the cylinder, which it was picking up on the InnoVise site map, which was 0.73 for the right eye and 0.36 for the left eye, and we went ahead and corrected it. Now, why did we do this? Because when we had the zero refraction, where we don't treat any refraction on the planning entered, you can see that the right eye, there is some amount of ablation even with zero refraction, which is 5 and 11. That means it's an irregular surface, and same thing for the left eye. So if I would have corrected just a sphere for this patient, this coma kind of a trefoil kind of a profile wouldn't have been corrected, and the patient post-op would have had 20/20 but a poor quality of vision. And this is the ray tracing based epithelial map. You can see there is some amount of irregularity present here with some amount of difference in the diopters, but when we did a Wavelight Plus, the post-op map looks like this, and these are some of the ongoing studies where the Wavelight Plus takes care of the it was 10 minutes, okay. Where it is taking care of the aberrations as well. So the patient satisfaction rate with Wavelight Plus is increasing to 92%, sharper rate with 85% having no complaints of glare and halos. So to conclude, we are moving towards a customized LASIK, and Wavelight Plus will help us to have a better patient satisfaction and quality of vision. Thank you.
Okay, thank you. Are we going to have the next pre-recording?
This is if we could have the pre-recorded talk brought up, thanks.
Hello everyone, my name is Chloe. Thanks to Dr. Kruger's invitation, it's a great honor to join the APO meeting remotely here to discuss the rapid rise of customized LASIK in China, the world's largest refractive surgery market. Refractive surgery has a tremendous advancement over the past 2 decades, with LASIK remaining at the forefront. Customized LASIK has emerged as the fastest growing procedure in recent years, revolutionized the field and reshaping patient expectations. Today, I will share insights into this growth, the driving factors behind its success, and what it means for the future of refractive surgery. This is my interest disclaimer. I'm an employee of Eye Hospital Group. And a brief introduction of myself. My name is Chloe, and I'm Associate Director of International Communication and Collaboration of Eye Hospital Group. I'm now responsible for Eye's group level international individual institution level collaboration project, information sharing, and we're trying to build a platform and channel for the foreign experts to learn from the Chinese doctors and learn from each other and communicate with each other. So let's start with the China refractive surgery market overview. So China represents not only the largest, but also the fastest growing refractive surgery market globally. Several key factors contribute to this unparalleled growth. High myopia prevalence, like over 600 million people in China affected by myopia, with increasing cases of high myopia among the younger generation, and the growing middle class and disposable incomes give more patients the choices that can afford for elective procedures, and also technology advancement and the growing patient awareness. So let's see some numbers over the past 10 years. So during 2015 to 2090, the market experienced a compound annual growth rate, the CAGR, with 30%, making it the most rapid expansion period. The key driver including the technology advancement, increasing customer confidence in laser vision correction, and the rise of the private refractive centers. So from 2020 to 2023, despite the continual expansion, the growth rate slowed down to about 20% of the CAGR to external factors such as COVID-19 pandemic, the temporary economic fluctuation. However, the increasing demand from second-tier and third-tier cities has sustained the overall market expansion. So over the past 20 years, private eye hospital has played a significant role in advancing refractive surgery by actively adopting the innovative technologies, training the specialist professionals, and enhancing patient education. And today, the top 3 private eye hospital group in China account for about 45% of the total market. Among all the private eye hospitals, Eye Hospital Group is the world's biggest one in terms of location, patient volume, and treatment volume. Here's the map of our group presence. We have more than 750 eye hospitals providing comprehensive eye services in China mainland, and also with over 130 eye centers around Europe, 1 center of excellence in the United States, 17 in the Southeast Asia. So for the last year, 2024, our outpatient visits are exceeding 15 million, within which we have a 2.6 million for refractive surgery. And we treated people with 1.2 million, and within which we have 0.8 million refractive surgeries. If you want to discuss the evolution of the refractive surgery, future development trend, and the potential insights of other markets, IR is an indispensable and crucial piece of the puzzle. Here, let's take a look of how IR's group's refractive surgery procedures evolved between 2023 to 2024, and what significant development took place. We have observed that in 2024, despite less than ideal macroeconomic expectations, customized LASIK was the only procedure among the 3 mainstream refractive surgery techniques, LASIK, SMILE, and ICL, to achieve the growth in the surgery volume. The growth share of the customized LASIK primarily comes from the traditional LASIK and ICL procedures. Since the official installment of the VFlight Plus at the end of 2023, its excellent clinical outcome has given doctors great confidence. Moreover, the positive pricing impact brought by VFlight Plus had helped the customized LASIK maintain a year-over-year revenue growth despite intense price competition in the market. Now, let's move to the slides for the post-op vision quality analysis. Based on our data in 2024, the VFlight Plus shows very good results in our system comparing to other mainstream surgery types. So under the strict standard process management, rigorous medical quality control, the continuous training of doctors, the post-op outcome of all refractive surgery procedures have been improved year by year. But you can say that VFlight Plus performs the best among all the surgery types. You might be curious, if we perform refractive surgery for around 400,000 patients annually, what does our patient conversion process look like? Let's take a look of our conversion rate funnel analysis. Here are the patient conversion data from January to November 2024. During the period, we had approximately 500,000 first-time visits to our clinic, with only about 4% not ongoing any examinations. Among the 96% who did proceed with examinations, 1.7 were diagnosed with absolute contradictions. Around 9% required further examination, and approximately 85% meet the surgical criteria. Ultimately, about 66% of eligible patients scheduled and completed the surgery. Our team carefully analyzed patient attritions at each stage of the process, ensuring that every patient is followed up by a dedicated customer service representative. We continue to refine our patient management outflow and improve the conversion rate from consultation to surgery. In this process, AI has begun to play a significant role in our group, providing valuable support in patient communication and management. We firmly believe that AI-driven solutions will be an inevitable trend in optimizing patient engagement and service workflow in the future. A special thanks to the Alcon China team for providing me with this 5-year forecast for the corneal refractive surgery market in China, as well as the insight into the penetration growth rate of WaveLight Plus since its market launched in December 2023. I think very strong penetration after the demo period since May 2024. At the same time, we can also see the WaveLight Plus installations data as the data at the end of 2024. In mainland China, a total of 81% units have been installed, with 58 units in IOL and 23 units in other private and public eye institutes. Next, let's take a look at the price trend of the refractive surgery over the past decades. According to IOS data, which provide a high timely reflection of market change on pricing, we observed that until 2021, the unit price of refractive surgery remained stable with a slightly upward trend. However, after 2021, the average unit price began to decline, with 23 to 24 being particularly challenging periods. During 22 to 23, the post-pandemic period triggered a surge in demand for refractive surgery. However, in this period, due to intensified in-market competition and a generally downside economic outlook, the average price experienced a notable decline. For different procedures, that's how the average price dropped. So at this very critical stage, the adoption of new technology has helped us to stabilize the pricing system. Take a look at the bottom left chart. The dark blue line represents the monthly average price trend in 2024, and the other one shows the 2023 trend. So in July 2024, we officially launched the Smile 4.8, and in December 2023, we began to installing WaveLight Plus. You might be wondering why the average price is the lowest every June. The reason is that in June, the military recruitment reason, the high school graduates who which enlisted need to undergo vision correction surgery during this time. As a result, the volume surged with a significant portion of the patient opted for more affordable procedures, leading to a drop in the average price for the month. So at IOL, we offer a comprehensive range of the procedures, caring for different patient needs within the scope of the surgical indications. Okay, let's make some conclusions from here. So what effects have driven IOL's success in adopting the new technology? For example, the SMILE and ICL. I think there are some 6 factors, which is very important. So first of all, we have a sufficient patient population, and we have a comprehensive clinical data collection, and we constantly improve our clinical quality standard. And also, IOL has a very strong brand influence, and we contribute a lot in the patient education programs. And also, with the continuously technology innovation and efficient market response of optimizer feedbacks, it helps us to bring those new technology to the market. And why does the customized LASIK have a strong growth potential? From my perspective, I think that more doctors are evolving in design for technical solutions, and this technique is advanced and exceptional well at the present. In a high competitive market, the doctor's skill is more crucial, and it can withstand the impact of the price war in a fairly competitive market. Of course, and we have continuously observation shows excellent clinical outcomes of the customized LASIK. Here, I also want to present on behalf of our doctors, Dr. Xiong Lu from our Eye Hospital Group, and also Dr. Kruger will talk about next about the concept and the global data for ray trace LASIK. But this is just to say the Chinese market presented by IOL has been embarrassing its next level of the customization with a great growth rate than SMILE in the past year. In the 6th center research, with 1,083 eyes have been treated, the 2020 rate has been 93%, and the 2016 rate has been 74%. And there has been only a mild increase in overcorrection with approximately 0.33D, which is believed to be due to patient accommodation during the setup testing. These results are reflective of early adoption by the world's largest market and may improve a certain experience with technology improve. Thank you very much for your attention. It's really that I want to be here in person. I hope I won't miss next time. And I hope that you will enjoy.
Thank you.
All right. Okay. That was a quick one. But thank you very much for that great presentation, Chloe. I know you're not here, but that was very well encapsulated in terms of what happened during the whole pandemic and now, how it's turning out. Obviously, we have a live session next, so we have one of the greatest pioneers in this field of refractive surgery, Dr. Ron Kruger, who's going to be talking to us. He's from the USA, and he's going to be talking to us about US FDA multi-center trial on ray tracing guided LASIK with an individualized ablation profile.
Can we get somebody to help me with this? That's it. Okay. Okay. I'm going to talk a little bit about the US FDA data and some of the global outcomes of this new ray tracing profile, which we've been talking about so far. And I'm from the University of Nebraska. Let's see. Disclosures, I am a consultant for Alcon, and I was the coordinating investigator for the US FDA trial, which was 9 centers, 336 eyes, with a year of follow-up. And this is really with the first public presentation of the US FDA data, which was just approved last month. LASIK is really a tale of two pathways, that of simplicity, safety, and speed versus complexity, quality, and customizations. And intrinsically, you'd like to get the procedure done quickly, safely, and efficiently, but you also want to get the best possible outcomes and quality with your results. And it's a little bit of a dichotomy. So if we look at femtosecond LASIK overall, it is the simplest way of doing it because you're just putting in the refraction and treating. It ends up being safe and predictable, and you get good outcomes. However, if you do something like topo-guided, which has been growing overall on a US and also global perspective, there's some complexity in the planning. There's customization with the correction of aberrations. But we are achieving sharper qualities, and we've been able to actually show statistically better 20/12 and 20/16 results with this technology. Now we're looking at a whole new platform called ray tracing LASIK, which is also complex and customized. However, it's an all-in-one device that's capturing the data, so it makes it a little simpler instead of capturing through many different devices. And the planning process is all automated by the technology with artificial intelligence, so it makes the whole planning phase quicker. And yet, it's the sharpest quality that we've seen so far, so we're still maintaining that quality aspect. So really, it comes down to three major areas: simplicity, speed, and quality, which is based on this all-in-one device, the faster planning, and the sharper outcomes. With simplicity, it really captures 3 different measurements that looks at the ocular wavefront, the biometry, and the corneal tomography, and then captures that in and creates a digital twin model eye, unique to that particular patient. And it takes about 10 minutes or so to capture all this data in multiple sequences in order to build a model, but from there, everything is automated thereafter. What's required is a pupil size that's greater than 4.5 millimeters, preferably greater than 6. The sight map is the actual device that captures it, and it will ultimately calculate that best refraction based on a 4 millimeter pupil average, and you then have to kind of correlate that with your manifest refraction under those light conditions, just to make sure that you're in the right place. And then finally, you can get iris registration with that to do the treatment. With the faster planning, this avatar or digital eye twin is individualized as a 3D mathematical model of the eye. The automated computation is done through ray tracing, where 2,000 rays go through this model with multiple iterations to come out the best correction. And finally, there's a compensation in the ablation that takes into account wound healing and biomechanics to get the ultimate outcome post-operatively when things are stabilized. This overall data of the speed and faster planning is based on comparisons with the 3 devices independently, and also compared to Contura as a planning mechanism with nomogram and cylinder compensation. This is a much faster process being automated. Again, looking at that avatar or digital twin model creation, what you can see in this particular image, that the actual wavefront is telling you all the information in the refractive profile from the retina to the front surface of the lens. It then gives you the simulated best profile shape on the front surface of the lens, and the rest of the imaging is captured with the tomography, the biometry, and then correlating that all together in the ray tracing model. Then finally, the automated computation allows you to iterate that on the actual surface of the eye to come up with the best ablation profile for the surface. Finally, that compensation looks at the profile as it's treating the periphery, where you get some ovalization of the pulse. There's generally losses, and this is all compensated for, as well as wound healing on the epithelium. Looking at the quality, our FDA study has been finally approved, and again, there were 9 centers in that FDA study, of which I was a coordinating investigator. And as the overall modality or methodology, patients were greater than 21 years of old, up to a -11 with 4.5 of cylinder. Endpoints were just our overall results with ±1 diopter or 20/40 best corrected, as the FDA specifies, and safety endpoints in terms of looking at those that lost 2 or more lines or had flap-related ocular SAEs. Our results overall with the 336 eyes is that 98.5% of patients were within 1 diopter of target correction, 92% within a half. 92% achieved a 20/20 or better outcome, and 67% at 20/16. And again, there were no ocular serious adverse events. Looking at the data here side by side, you can see again that 67% 2016. Gains of lines gained of vision is about 19 or 90% 1 line and 2% 2 lines, so 21% altogether. Also looking at the manifest refraction, 98% within 1 diopter, and you can see this nice cohort where they're tightly in that range, and good stability over the 3 months and ultimately 1 year follow-up. Overall, if you look at the scatter plot, there is a little bit about 3% overcorrection seen, and this could be due to accommodation, which you have to watch for during the treatment. Looking at astigmatism correction, overall there was 92% were within a half diopter at the 3 months, and there was a modest overcorrection of cylinder here at about 8%, 1.08, so 8% increase in cylinder, and some of that has to do with the overall correction with accommodation also factoring in. There were no safety endpoint concerns and good stability. And then ultimately, if we look at what else has been published on a global level, 2 studies in the last 2 years, a multi-center study out of Europe and Australia, as well as a single surgeon study out of Australia. Looking at those 2 data sets, you know, pre-treatment or preoperatively, here 78% were less than 4 diopter sphere, 80% less than 1 diopter cylinder, so there was some higher myopes there too. In the single surgeon study, it was a little bit higher myopes and higher cylinder overall. But when you compare them directly, you can see they're all giving some of the best results we've seen to date. Here, over 50% of patients are seeing 20/12.5. Here, about almost 90% are seeing 20/16, which is really great results. Comparing the 2 studies side by side here, you can see lines gained were really robust, even close to 40%, 1 or more lines gained. Some lines lost overall, but this is looking at really good outcomes in general. And finally, in the single surgeon study, it's the first time we've really seen that there's no increase in higher order aberrations going from pre to post, and statistically, spherical aberration was actually decreased. So first time we can actually see we're reducing the aberrations despite the correction of higher levels of myopia. Here there was 20% were over 5 diopters, and yet we're reducing spherical aberration. Looking at post-op outcomes here with regard to astigmatism, there was a little bit of an overcorrection. Again, sphere and cylinder could be up to about 10 or 12% overcorrected, but those numbers are relatively small with cylinder. Finally, looking at our data here, that number comparing ray tracing LASIK with other customized modalities, showing some of the highest visual acuities of 20/12.5. And in conclusion, custom LASIK will continue to push us closer to this concept of supervision. The WaveLight Plus is bringing us one step closer to this process by the personalized 3D model, or the digital twin, eye avatar. And this simplicity, speed, and planning of iterative refinement with the algorithm and pre-compensation are really allowing us to get the best outcomes to date. So thank you very much for your attention.
Thank you so much for your talk. That was wonderful with the three perspectives around the world. We are now going to switch up a little bit in the order as well. We've got our rising star, probably established star now, Dr. Ashwin Agarwal, who'll be talking about getting ICL sizing and astigmatic implantation correct. Thank you.
All right. I hope everybody can hear. Okay, awesome. I hope everybody's had a good lunch. Okay, that means yes, everybody is sleeping well. So getting ICL sizing right in a refractive surgery is extremely important because these are made with particular sizes, and what I mean by that is they are sized for each eye in a particular way, and how do we get this sizing right for each case is what this talk is all about. But more importantly, is also going to teach you some basics about phakic IOL in case you've not dealt with it before. I do have financial interest with LSR, but none of it pertains to the talk today. Just in interest of time, I'm going to be talking about one particular ICL, obviously, which is the star phakic IOL, which the reason is because the time is less and we have to cover a lot of topics under this belt. So understanding the ICL, first up, you have the orientation holes. Obviously, we understand that. Any way you spin this around 360 degrees, you will always get the orientation holes in the same fashion. One thing I used to do when I used to drive my car is just to remember the orientation holes are bottom left, upper right, is hold the steering wheel in that actual manner, which really helped. I mean, it's not, it's very accident prone, so don't try it. It's just the thought process. Some pearls and pitfalls when you're doing ICL. When you are doing an investigation, you want to be checking the AC depth and the white to white in order for ensuring the sizing. When you're doing the surgery, some pearls for loading the lens, and if you have a flip, what do you do? Post-operatively, you want to be checking the vault, you want to check axis in case the axis is not right, and other complications which I'll talk about. Investigations, obviously, I do a plethora of investigations, but the two most important ones being the pentacam and the AIOS2025-GP62, which basically define the AC depth, where my threshold is 2.8 and above is good for me to do an ICL. Some people like to keep it 3, especially in the beginning, 3 millimeters. Where the white to white, obviously, is basically to understand what size of an ICL you want to be using, and I'll come to that as we go, but these are some of the most important investigations that you want to be doing. When you're loading this lens, ensure that in the cartridge, you try not to have any bubbles. Air bubbles will prevent you from seeing the orientation holes of the lens, which I'll show you as we go along. Once the lens is loaded into the cartridge, you pull through mechanism is what we usually do. When you use the pull through mechanism, it kind of fits in well into that cartridge. Can we have audio?
For you to twist.
I'm just going to. All right. So it's important to know how do you mark this orientation hole out when you're inside the eye.
Outside the eye as a reference point for you to twist or turn the ICL in the right direction in which you want to implant. So let's say the 3 holes are in the straight line and this is the cartridge lock. You cannot see the ICL holes while inside the cartridge, but you can see the reference point outside. If by chance the holes are on the left, all I'm asking you to do is twist the cartridge lock in the opposite direction so the holes face you while you insert and inject the ICL.
So this one trick has actually prevented me from having ICL flips in the last 7 years straight. Just ensuring to notice where the holes are before you implant the lens and rotating so that the holes face you, that is face the microscope. That really avoids you having a flip inside the eye. That's one of the biggest fears when we do ICL. Uh, Obviously, an animation can show only that much, but it's easier to show it in a real-time scenario. So as you're going along, make sure that you're doing it slowly, ensuring that your orientation holds is in the bottom right, you can see here. And now the foot plates are lodged under the iris. The fourth one is always a little more tricky, so what I try to do is flip it on itself, and it goes and rolls back into the under the iris. So in cases of a flipped ICL, what do we do? When an ICL flips, you'll obviously see the orientation holes are not right, and you can have lens touch, angle closure, iris chafing, corneal decompensation, and much more. So this is a resident of mine actually who was without knowing, accidentally, intentionally making sure that the ICL was flipped. And now, one of the tricks, obviously, a lot of you are going to cringe because you've had lunch, and that's why I asked you for the lunch question, is basically to flip this ICL inside the eye. The way to do this is a lot of profuse viscoelastic, and push the angle push the ICL into the angle of the eye. And that really helps you flip this ICL. What it avoids you from doing is explanting. In the case of explantation, you can tear that ICL and not be able to use it at that point of time. And this, I mean, we've done about more than 10 or odd cases. We've not had too many flips, but that's our way of doing it. There is obviously you can do an explantation, and there are multiple reasons for explantation as mentioned here. You can do that in flipped ICL as well. In case you want to do an ICL explantation, the way to do this is actually to ensure that you can hold the optic-haptic junction, making sure that all ends are free. Once you hold the optic-haptic junction in this case, and just one pull-through mechanism through the same incision, it comes out. You really don't have to go and extend the wound in any which way. So it can be used even in a case of cataract in this scenario where you have a cataract after ICL. Not immediate, but after a few years. So in all scenarios, you can use that as your choice. And in the effect of the central flow, we all understand, obviously, there's a central flow. The advantage of this is basically it reduces the risk of angle closure, even if you have a high vault. It reduces the risk of cataract formation, even if you have a low vault. So these are some of the advantages of using the central flow. Nowadays, everybody's in the central flow, so you're fine. The sizing of the ICL, the Star company particularly makes it in these four sizes, 12.1, 12.6, 12.3, and 13.7. What you want to be ensuring is look out for these changes in case there is a issue. In case of what is the advantage of sizing, right? Vaulting. One of the biggest questions that is asked is what is a good vault and bad vault? 250 microns to 750 microns is an ideal vault. Anything below 1.25, 125 microns is a low vault, and anything above 1 millimeter is a high vault. So this is what you want to understand when you're going down to it. In case you are facing this issue of low vault, what are the management options? Obviously, the problems you can read and take a snapshot of this, but the management option is wait and watch. If there is no symptom, please just wait and watch. Don't rush into treatment in that scenario. Have a close follow-up on this patient. ICL exchange in case and increase the size of the ICL. If you're doing an exchange, increase the size of an ICL in case of a low vault. If you're doing ICL removal with cataract surgery in case of a cataract formation. Now, in case of a high vault, you want to be rotating this horizontal to vertical, because the sizing will actually, you will be able to gain 200 microns of lower vault because it goes into a little more snug fit. Second is IOL exchange. You can reduce, when you're doing an IOL exchange in this scenario, you can go ahead and reduce the size of an ICL. I'm sorry, that was an ICL exchange. Axis rotation, you have basically preoperative. You can obviously do the marking with the digital, with the manual markers. You can also use the slit lamp visualization models or the digital markers, whichever way you want, to ensure that you can get the axis right in these scenarios. Some of the other complications of ICL, as you already know, could be endophthalmitis, CMEs, any damage to the ICL which is intraoperative, retinal detachment, and uveitis and glaucoma. So these are some of the pitfalls and pearls that I would like to give on ICL. Should you want to do this, obviously we have the next up, new techniques with Naren, who will be talking to us a little bit more about it. Thank you very much.
Always so practical and eloquently delivered. Dr. Agarwal, thank you so much. I'd like to now introduce our next speaker. We're just running a little bit short on time, so we're going to tuck the questions at the end. We have Dr. Robert Ang, who's going to be talking about, yes, the ICL. No? Oh, okay. Rohit is going to be a little bit delayed. And Robert was after, right? Yeah. I was going to be talking about ICL Evo Viva as a secondary implant for presbyopia correction. Thank you.
Okay. Good afternoon. I'm here to share with you my experience with the Viva ICL. Here are my disclosures, and I'm an investigator for Star Surgical. So the ICL is probably an ideal treatment for presbyopia because many patients who come to our clinic have both refractive error and astigmatism, and if they're above 40, they want a simultaneous treatment. So it does not need removal of tissue, we don't implant inlays, and it spares the eye from problems with future IOL calculations. I usually don't do clear lens exchange in our clinic. We want to preserve the residual accommodation of the patients, and there's less risk of retinal detachment if you do ICL versus a clear lens exchange, especially on a high myope. So we don't modify any of your techniques. So if you do a EVO ICL, you'll have the same surgical techniques as the presbyopia ICL. You won't need lasers. You'll have a refractive surgery center of your own without a laser. And they're reversible, removable, exchangeable, and upgradable. So presbyopia, as we know, is challenging because patients want good far and good near with no side effects, which is not true. There's always a downside, there's always a compromise. But the Vivo ICL, it preserves the cornea and the lens. So that's one of the advantages we want to keep. So the EDOF ICL is this refractive design. So it is not a multifocal ICL, but a refractive change from the center to the periphery. The center has this add power, which gives you around a diopter of near add, and it's unidirectional, so from center to outwards. It provides an additional depth of focus. So it adds a little bit of depth of focus, and it takes advantage of the reflex of the eye wherein when you do accommodate to read near, your pupil becomes smaller, so you're looking through the add part, and then when you look at distance, you're looking at the distance part, similar to your EDOF or monofocal IOL, monofocal plus IOLs now in the market. So similar principle as that. So we are on our 2-year follow-up of this study with non-toric and toric ICL, Viva ICLs. So we started about 3 years ago recruiting the patients. So it was the second study. We did our first round maybe 7-8 years ago. And this one now, we have toric powers. So patients with high astigmatism or even moderate astigmatism can be recruited into the study. So we have 94 treated eyes. 68 of the eyes were toric, and some of the eyes, one eye was toric, one eye was non-toric, so we included them in the study. So 72 eyes now are beyond 6 months, and about maybe half are beyond a year. So the mean age of the patients in our study was about 49 years old. So in terms of refraction, so the difference between this study now and the previous study is we adjusted the nomogram to be a little more first plus in terms of targeting. So we wanted to be more planar or emmetrope in the outcomes. As you can see here, the intended correction now is nearer the line, where achieved and intended are near that line. And in terms of MRSE, in the beginning now, we are a little bit on the hyperopic side, about plus a half, and then it kind of regresses to the near plano. So now we see that the refraction stabilizes at near plano. The cylinders of the patients have a mean of 1.5 diopters. And 92% of the eyes were within 10 degrees of rotational stability. So in terms of visual acuity, about 80% were 20/30 or better. So this is an EDOF ICL, so it cannot give J1 near. We know that, and we explain that to the patient. So our target is about 20/25 distance, 20/25 intermediate, and about J3, J4 near, which in this cohort, we see that 80% are 20/30 or better, and 70% are 20/25 or better in distance. 81% are 20/25 or better for intermediate, and about 80% are 20/30 for near. Distance-corrected near vision, 75% of them were 20/30 or better. So in terms of the focus curve, compared to a non-EDOF eye, we see that there's a wider range of the focus. I think we are adds about 1 diopter to 1.2 diopters of near add to the eye. So we tested contrast sensitivity, and we see that mesopic contrast with and without glare is very similar in terms of normal from pre-op to 6 months, and with and without glare photopic is also very similar. So we also checked for patient satisfaction, and we see that most patients were happy with their correction. So most of them didn't complain about glare halo so much. And activities, there was no limitation of activities. They were satisfied with their correction. And some of them do need some reading glass for very small print, but most of the computer patients, they felt good that they can see their laptop or their computer screens very well without glasses. So patient satisfaction definitely was better. So they were between somewhat satisfied, very satisfied, to completely satisfied, about 3.6 to 4 in a scale of 5. So in terms of patient selection, what we do is we stick with 40 to 55-year-olds. Above 55-year-old, of course, the RLE option comes into play. This is a myopic group of patients with astigmatism. We follow on-label above 2.8 millimeters of anterior chamber depth and above 2,000 cells in terms of endothelial cell count. I check the DLI, or dysfunctional lens index, to make sure that everybody's above 9. So if you have an eye trace, a pentacam, sometimes you don't see that there's a cataract, so it's best to check because these are presbyopes. With the study, we wanted less pre-op total higher order aberration, so we were choosing patients who have less than 0.25 microns of total HOA and angle kappas of less than 0.5. The surgery, as I said, is the same with EVO ICL. So there's no difference in loading, implanting, and post-op care is the same. So I use loteprednol instead of Predforte to avoid IOP spike. Again, with presbyopia patients, when you treat, it's hard to promise everything. So we counsel the patient, same as a trifocal and same as an EDOF, that there's a little bit of trade-off. You won't get perfect far, you won't get perfect near, you have somewhere in between. But it helps you with day-to-day life, and it helps to have aggressive dry eye therapy. So having the EDOF Viva ICL with toric and non-toric function, it's a great option for presbyopic patients who are not yet ready for lens extraction. Patients have good enough satisfaction for distance and intermediate vision, and they have functional near vision, and the toric performance is similar to the spherical performance. So it allows us a presbyopic treatment that preserves the cornea and lens for future IOL innovations. Thank you very much.
Awesome. Thank you, Bobby. Next up, we're going to have Naren Shetty talk to us about new methods of improved ICL sizing.
Oh yeah, full screen, yeah. Okay. Super. Good afternoon, everyone. On this onset, I would like to thank APAO and AIOS for giving me this opportunity. Now, in my talk, I'm going to just briefly touch upon the newest ways of wall calculation, but mainly I want to talk about our in-house AI-driven software. Anyway, these are my financial disclosures. Now, there is a device called as Artemis Insight 100 UBM. This also is a fantastic device which objectively you can actually calculate really helps you in the right calculation of STS and other parameters like wide to wide and so on and so forth. And the repeatability and reproducibility is almost 95%. So this is a fantastic objective way, because a regular UBM with the STS is very subjective. It really depends on a person who's doing the scan. Now, there's also a formula called as Reinstein formula, which has 94% vault within the 300 micron meter of their target. Then we have ZZ ICL wall predictor. The wall prediction error is 88.1% within 300 microns and 100% within 500 microns. Then we have the NK3 formula, which has a mean vault ranging from 533 plus or minus 203 microns. And also we have something called as KS formula. This basically, it showed that angle-to-angle measurement is a better predictor of the vault than our regular wide-to-wide measurements, which we've been used to. Then we also have a couple of AI-driven softwares like the ICL Guru, which vault prediction error within 250 microns is 97%. And the LASIK formula is also a fantastic machine which uses, again, an AI-driven one which uses the Antrion. So anyway, so coming to our story, now, I'm sure each one of us have had days where we have done a perfect surgery. Like you have done the perfect calculation, you have done the surgery. Next day you see the patient is very happy, the vision is fantastic. But when you look at the slit lamp or the OCT, you see either a high vault or a low vault. Now, why does these kind of cases now and then crop up? This is happening because we rely too much on horizontal wide to wide. And we do certain assumptions that the horizontal wide to wide is always maximum, vertical wide to wide is always minimum, which is actually not true. So can we actually have a better prediction or predictor for the vault? So to do this, first we took the pentacam densitometry scan. We plotted the 256 grayscale. We saw the rate of change of densitometry, and that way we could identify the exact wide to wide from the pentacam data itself, and then we plotted it. Now, what was incidental finding was, what was very interesting was the shortest wide to wide correlated exactly with the steep axis, which was very interesting and never been documented before. And this is something that we even published the data too. But anyway, let's move forward. By using the same method, we calculated the max and minimum wide to wide, max and minimum angle, horizontal wide to wide, and vertical wide to wide. And we took all this data and the rest of the pentacam, refraction, ICL parameters, UBM predicted vault parameters, and then we added AI into it. And basically, we found something very interesting. The new estimated postoperative vault, now the coefficient of determination, R square, was 0.74. Basically, the closer the value is to 1, the better performance it is. And also the interclass correlation coefficient was 0.92. Again, closer to 1, the better performance it is. Now let's look at the R-square of every other formula which is there, which can range from 0.13 to 0.4, and the LASO being the R-square is 0.68, and our formula is performing even better than this. So basically, with the novel 3D corneal diameter profile and the AI-driven ICL sizing, we can predict the vault much better. And like I mentioned earlier, the coefficient of determination was 0.74, and the interclass correlation was 0.92. Thank you so much for your time.
We're going to go ahead and open up some time for discussion. We do have a little bit of time left, and we do have 2 other speakers who have not yet arrived, so we'll give them an opportunity to show up as well as we have the discussion. So we really kind of designed this program to cover customized LASIK, because LASIK itself is still a viable procedure that we all do as a refractive surgery, but we're moving forward by seeing increasing levels of customization. And of course, another procedure that's becoming more popular is SMILE or LEX procedures. And the question is, which of those procedures are going to tend to dominate more in the future? I think we're all kind of curious about where that's going to go, and I think could be a good opportunity to talk a little bit about customization, which can deal with quality and a little bit more detailed personalization versus the speed and simplicity sometimes of doing a K-LEX procedure. So I kind of would open it up to our panel a little on what your thoughts are about things like a LEX procedure versus a customized LASIK.
I think we are definitely pushing the boundaries of our LASIK guide, and obviously it's accessible, it's widely used across the world. I do think that our LALEX procedures have a little way to go in terms of customization, and the fact that we're dealing purely within that stromal bed, and then the impact of whatever impact we might think that dissection may have on that, I think will also impact, because with LASIK it's obviously lift, ablate, replace. But there is that degree of manipulation involved, and I do wonder in terms of the customizability of LALEX procedures where that would take us. The other thing I always wonder about is obviously these patients are young, and we're wanting to, provide the best at the point of care. But what happens when they develop a cataract and we've just ablated all of these additional parameters into the cornea, and then suddenly we're going to remove a lens that is now dysfunctional? How do we deal with that then?
Right.
So if I can, so personally, sir, I would say is, I think both the technologies are fantastic, but if you really say, okay, side by side, a real comparison in terms of the quality, I think the Wavelight Plus is far ahead, because it's even like personally when we did a study where we looked at 50 patients who have done it, I think very similar, almost 68% of the patients were better than 20/20. And the quality you deliver on day 1 itself, I feel it's going to take time for lenticular procedures to reach that level. I don't think so, because if you look at right now, still the cyclotorsion compensation itself is not automatic. You cannot, for a refractive, you cannot mark things and then, I mean, there itself you're inducing error, because there only 2% error is gone. But here the registration was always there, and that's why, especially if the patient has astigmatism, they always clearly outperform a lenticular procedure period because of the manual marking what we do.
Yeah, I think there's a lot of things being said on both sides in terms of what is it that the surgeon wants and what is it that the patient wants. Surgeon wants to have quick, efficient, fast procedures that are going to deliver really good outcomes that patients are going to be happy with. Patient wants to see the best they can possibly see, and we kind of underestimate that a little bit, because we think, okay, they got a 20/20 outcome, they should be happy. But then they look at these nuances that are imperfect in their vision, and they're bothered by them. And you always know what a patient says when they get an exquisite 20/16 or 20/12 outcome, and they're like, I've never seen like this my whole life. I can see the veins on the leaves in the tree, and that changes everything for them. That's a game changer. And so it is a point that we want to drive forward, is to say, let's keep pushing to get better and better outcomes. Now, you've made a point about if you're changing a total aberrated pattern on the cornea, what happens when you get a cataract later? Because you're going to still have to do another procedure. But even when we were doing Contura, and it was just topo-based, we were creating a more ideal surface laser procedure, or or corneal changing procedure that was going to make a cataract surgery better in the end because it was correcting on the cornea. Now we're taking it a step further because it's ray tracing, but we're not going to change it that much. Most of the aberrations are on the front surface rather than inside. We just want to perfect it as much as possible for the patient right now.
It's wonderful. I spy one of our speakers in the audience, Dr. Rohit Shetty. I'd like to invite him up to speak about topography-guided laser vision correction, but in highly aberrated eyes. Thank you.
Which is another reason why we need customized procedures.
So I'm going to speak about the topo-guided treatment in highly aberrated corneas. These are my financial interests. So when you look at aberration, you are trying to look at both the quantity and the quality of vision. And you end up in different aberrations which are related to old RK being done, a very poorly centered ablation, patient with regression, and also when you're looking at keratoconus. So what are the challenges associated with handling them is your blurred vision, the challenges of glare halos, night vision challenges, eye strains, which comes with compensating for these aberrations, and all this have a huge impact on a low quality of life. So what we have is options of topo-guided treatment. We have an options in, we call it TREC, topo-guided removal of epithelium and reshaping it, and corneal remodeling and shaping. So when you look at topo-guided treatments now, we have, we call it TCADs. You have a platform from Alcons, we have a platform from Zeiss, and we have also a very strong platform from Schwinn. The Schwinn looks at two things. You look at an ocular wavefront, which is a total wavefront using their Pyramis, which is their abrometer, and also the corneal wavefront, which looks at more regularizing the cornea. But challenges here is, when do we choose and what do we choose? Many times when you have only corneal related aberrations, the amount of ablation is huge because it assumes that everything is the cornea. There was only one lens in the eye. But when you have a cornea which has a total aberration, it neutralizes a lot of aberrations from the lens. Lens neutralizes aberration, so the amount of ablation on the cornea gets minimized. So it compensates for what is already happening, which is naturally happening in the eyes. So the ocular wavefront, if you have a good abrometer, in that way, the pyramidal wavefront abrometer of Pyramis from CSO is excellent. Even in the most aberrated eye, you're able to get a really repeatable and a decent aberrations. You're also able to change the aberrations. Some of those, when you have a high level of aberrations being treated, your ablation depth increases. So you can actually, machine itself knocks off the ones which are not important and just treats what are significant in your procedures. And you always look at the amount of coma, what axis is your coma, and it gives you in both in microns and diopters, which also has a huge impact because you know that this amount of coma will be disappeared or will reduce with this axis when you're treating these aberrations. So it's always very interesting with how softwares are trying to help us in understanding full aberration profile rather than just telling you this is what you treat, this is how the ablation profile is, and then finish. And these are a few examples when we have been able to treat. We have been doing it for the last 8.5 years now, and we have just published long-term results of this with very stable refraction and very, very small number of patients who needed a repeat cross-linking. But when you have a cornea which is thinner and when you feel that the aberrations are, when you don't have enough tissue to do the topo-guided treatment, we designed a technique called a TREC, where you are able to do a small PTK over the corneal zone, the corneal cone, When you do a PTK on that, you can customize this, and this is how you do. You localize the cone, make an ablation profile, and this is a small PTK on the cone, and then you can knock it off, and then later you do a cross-linking. Again, we published this work in JRS, long-term results of this, and this has been quite amazing about how this can help in improving the quality of vision. And these are just a few cases which shows that just by this is more like a very customized cretin protocol. Cretin protocol by Kaimonis showed that you can do a PTK and it kind of improves the quality of vision. And this is a combination of how we did the both 1 year data of track cancer topo-guided treatment. So what I'm going to talk now in the next few minutes is about using the ray tracing principle and how ray tracing algorithm is now coming into fore beyond our conventional abrometers and topo-guided treatments. The new abrometers, which uses the ray tracing, does the ray tracing from your epithelium, because epithelium forms a very important refractive surface, the anterior and the posterior. The posterior ray tracing is very important because most of the abrometers extrapolate the data or assume certain amount of change, which cannot be assumed, especially when you are doing irregular corneas. And the area of what we are working is with the company called IOS. They have their own machine here. If you are interested, they use a Precisio, which is their abrometer, which is ray tracing abrometer. They put a lot of efforts on the pupil size. They use 8 different pupil conditions to get the right optimal size, and their optical zone is based on that ideal pupil size. And this is a ray tracing of your epithelium, ray tracing in terms of refractive map. This is the corneal ray tracing. And the zone, optical zone, is based on your pupil size, and then it uses a ray tracing map. It includes the epithelium and also looks at how the epithelium would heal post-op after a particular surgery is done. So a customized transition zone, for example, the transition zone is not equal. It's customized transition zone according to your pupil and according to the area of how it works. And these are the ablation maps, and this is how, especially in a pellucid, these are the ablation map, what it does, and this is how epithelium now has become much more regular post-surgery. And there's a few images of outcomes, what we see in the right and left, and it's quite amazing how the next generation of these ray tracing are going to change the way we see our refractive patient. And you can see that how the keratoconus is now being able to, we can work on it like how you're doing a LASIK or a refractive procedures. So there are still challenges of flattening, altered accommodation, epithelial remodeling, and neuroadaptation. And these are all the challenges which we feel. The eye has been adapted to a certain level of accommodation. This is on the Osiris. This is how the accommodation happens, and we are able to measure these accommodations. And these challenges, if you're neuro-adapted to a certain level of accommodation, these things don't change much, and the patient's quality of vision may improve, but the refractive error may not really fully change. That is something which we need to keep it in mind. So topo-guided laser vision has been a revolution and in highly abrated eyes, and they've been a big boon. And ray tracing technology, I think, would be the future of how topo-guided treatment will be done, with more AI-driven process and understanding of biomechanics, wound healing, and also when we look at the future of adaptive optics, where you can choose what aberration to treat, I think we might end up in highly customizing the irregular corneal ablation. Thank you.
Okay. Okay, so we do have a few more minutes for some discussion, and I think we kind of led into that a little bit, and there are still some good points to discuss. So we left off a little bit talking about, is customization going to be more of the future? Are some of the simplicity of LEX procedures going to be the future? Rohit, you might want to even weigh in because you're doing a number of the newer KLEX procedures. How is it sort of impacting your practice to be offering various levels of customization, but also these newer LEX procedures. And what is it that patients are looking for?
See, at this point of time, a lot of us are still choosing the type of procedures based on the economics, what patients want to pay. And I think what we are trying to do is, for example, trying to customize when not to give them a choice to do it, rather than trying to give them an transparent opinion that certain cases are not good for certain procedures. For example, if the patient is a contact lens intolerant and he's got a lot of epithelial changes, and these patients would probably benefit more from a KLX procedures, CLEX procedures than refractive lasers. Or somebody has high level of aberrations, or somebody has cornea high level of cylinders, and we still are not reached the stage in CLEX where we're able to treat this with certainty. So we have to do a lot of this customization, and this customization helps to make sure that your patients are getting the best and not just the economics is ruling the decision.
That's a good point.
On that note, when, say for example, if we wanted to leave the cornea alone for a bit and just transitioning to the comparison between that and ICLs, Ron, I noted in your study that you were accepting patients up until about -11. And I think in many surgeons' hands, when we start to approach those levels, we'd probably migrate to an ICL for several reasons. Not only is it reversible, leaves the cornea alone, etc., but the quality of vision is great. And I saw it was quite interesting, your point about the spherical collaboration improving in these patients, so it's demonstrably better with tailored, customized LASIK. But would you, in terms of the comparison between an ICL and a patient that was around about -8, -9, -10, where are you hedging your bets now? Are you still an ICL candidate, or are you bang on the customization profile there? Because now it looks like the quality of vision might actually approach that of what people are gaining from an ICL, that extra line, but also that extra quality.
Right, and I think that's a good question, because as Rohit was saying, sometimes it's based on price. You know, our ICLs are going to be more expensive than our LASIK procedures, and sometimes patients walk in the door and they're thinking LASIK, and if you're trying to sell them an ICL, they get disinterested, you know, and so they can kind of steer that a little bit. And that makes it important to say we can still provide really good LASIK procedures, quality ones, and get to some of those higher corrections and satisfy them where they need to be. Of course, too much correction on the cornea is not going to be good when it comes down to the time of a cataract surgery later, and so we have to do something that's going to be smart for the patient long term.
That's wonderful. And on that note, with ICLs, Robert, the world is interested in the presbyopic correcting ICL for sure. It seems to hopefully fulfill a niche space that is currently unfulfilled. I noticed with your refractive outcomes, you had modified your nomogram. Are you employing then any monovision, mini monovision techniques to try and get a little bit more spectacle independence in that group of patients?
When you have a presbyopic ICL available in your hands, you actually will have 3 possible options. Option 1 is bilateral ICL, whether you target both full correction or 1 mini monovision. The second option is 1 EVO ICL and 1 presbyopic ICL, just like some presby-LASIK treatments that I do, wherein I need to make sure that the dominant eye sees well. And the third option is your standard ICL with a monovision. So again, it boils down to experience what you prefer doing. Since I've been doing a lot of presby-LASIK where one eye is full correction and the other eye is, so one eye presby-LASIK, I'm probably going to lean on that experience more if I choose for a presbyopic patient. So, but again, it's not a multifocal, just like your IPCL, where it's like a ring. So it still does not give J1. So I need to brief the patient that even if I hedge to a minus 0.5 or 0.75 target, the EDOF lens will have a compromise in far vision. So I don't do that much monovision on them. So I still want to retain the EDOF advantage, because I think if you change the refraction, you also bring out some halos and glare, even with our EDOF IOLs.
So you're saying that if you do it where it's one of each, you won't necessarily offset a little bit to
up to
get more
minus
near.
0.5 only.
That's it,
Not
okay, yeah.
to minus 1, because
Right.
that's too much, I think.
Yeah.
Tiny little bit.
Yeah, tiny little bit.
So I want to ask Rohit about ICL sizing, because your colleague was talking a little bit about his way of kind of refining that, making it more predictable. Obviously, that's one of the biggest things about ICL, that we could get more adoption if the sizing was even better. So how much are you using some of these ideas in your practice now?
I think we're working on, like there are already some 2 platforms, one with Dan Reinstein, I think Zaldivar also has, where we are looking at these, but geographically, every eye has a different, our ACD is not 3.2, our average ACD is 2.9, 2.95. So we have to customize, and our white to white are smaller. I mean, our white to white is 11.5 to 11.9. So everything has to be relooked at it, and these formulas, what you suit a certain population, doesn't have the same, you cannot apply for the same different geographical population. So I feel that more and more countries are now looking at trying to customize their own, rather than trying to use something which is there. And so, say Pentacam's indices, as you are aware of it, that you have a different indices for Chinese population. They're working on something for Indian one. I'm sure they will have different Pentacams will come with different indices, which will have a baseline indices. Like a baddie of what works with your population, it works completely different with us.
Right. I mean, you still use UBM a lot.
Yeah.
You know,
Yes,
so
yes.
besides, you know, and that will give you some kind of core information, you know,
Sulcus
between
to
white to
sulcus,
white and
yeah,
sulcus to
yeah.
sulcus to plan it out. I think your idea of an AI program or analysis that can look at it and other factors, or create a digital twin of the eye that looks at
Absolutely.
all factors,
Absolutely.
and then run it through AI and say, what is the best size of
Absolutely.
ICL, and it's spot on every time.
Absolutely.
I think definitely that would be a game changer for those of us that are in populations that are quite heterogeneous,
Right.
in terms of mixed ethnic backgrounds as well. On that note about sizing, maybe I can pose this question to each of the members on the panel. How aggressive are you when it comes to a questionable vault in terms of rotation? Say we've got a spherical lens, patient's asymptomatic, quality of vision is good, patient doesn't think there's anything wrong. Do you upset the apple cart? How aggressive are you in terms of spinning that lens? Rohit?
If your gonioscopy is good, and you tell them, it's always important to keep them informed that we are giving them, because if you tell them everything is normal, they don't come back to you, and then we might end up in a challenge. So more regular follow-up every 6 months, do a gonioscope when they come, and there's any sign of warning, then, I mean, of course, if it's a bad vault, then we have to remove it. When you are in between, when you're not sure, now we have great OCTs which picks up everything. We have great, technologies where you don't need to rush and take a decision right away.
I have to say, I had one patient in my experience where between the 2 eyes, I implanted 3 different sizes of ICL. So I started off with one, and the vault was very flat. And so I went to the second eye, and I implanted the next higher size, and the vault was still flat. And then I went back to the first eye, which is the flattest, and I went to the even larger size, and it was still flat. And of course, with UBM, it was just passing right past the sulcus in every single one of those cases. And I had to tell the guy, I can't leave these in your eye, because it's pressing right up against the lens. It's almost a sure deal for a cataract. And as much as he hated it because he loved his vision, I had to explant those eyes. So there are some strange things with ICLs that, we still have to understand, like why this particular patient, I couldn't get it in the sulcus, even between 2 different eyes and 3 different ICLs. But, I didn't want to play with that, because long term that was going to be a safety issue for the patient.
Absolutely. Robert?
I use an ASOCT to monitor everybody. So I tell everybody come yearly because, as you said, sometimes they're low volt, but they remain above 100, so I'm fine. The high volts we're more afraid, but if they're above 1,000 microns, then I would probably push to remove. But if they're not, then observation is fine. They usually don't want to touch their eye because they see well. That's the challenge in all of us is the patients are happy. It's like we're panicking for them and they're okay. So I just show them the image of the ASOCT so that they know that this is why we tell you to come.
It's very helpful.
Yeah.
Do you have any questions from the audience? If anyone would like to come forward to the microphone, if that's the case, unless our panelists have any other questions. We've got about 5 minutes left in session. I don't think our last speaker has arrived.
So I'll go ahead. Perfect.
Yes, I would like to comment on ICL sizing. As you know, I developed the laser formula with more than 150 eyes.
Could we have his microphone brought up, please? It's just challenging to hear. Yeah.
Better like this? Okay,
I'll see you later.
So I developed the laser formula with 150 eyes implanted in my practice. And it was a good comment of Dr. Shetty saying that it was based on the Caucasian eyes, of course. And when we look at the Nakamura formula, it's based on Asian eyes. And there the size of the implants of the ICLs was mostly 12.1 and 12.6. Whether in my series was 12.6 and 13.2 with a mean of 12.9. So we are asking STAR for quite some time to develop a 12.9 ICL size. But it's very interesting to see that many the formulas are developed. We mentioned UBM. The ICL Guru is based on the UBM of Sonomit, and the Artemis works with Dan Reinstein. And our formula works with the anterior segment OCT, the MS39, not with the Cassia as was mentioned before, but with the MS. So it's also very important to know it's the MS39. So don't mix it with other machines, also very important. And it's also the Andrea Russo formula from Italy is based on the CSO MS39. And those both formulas are now available as a plug-in actually. You can download it from the internet and plug it into your device, the MS39. So you don't have to take the numbers and put it in the Excel file. So it's no room for errors anymore. So that's very important to know. Thank you.
Thank you, Eric. Can
Excellent.
I just thank you for making that freely available as one of the very few tools that we have that we don't have to pay $1 million for. So thank you so much for that. We've got any other final questions from the audience? Or from my moderators?
Yeah, I only have one more comment. Alcon is doing a launch event of WaveLight Plus in this country, and it's going to be in 10 minutes over at the Alcon booth. And if anyone wants to go, I'll be giving a little bit longer talk, going over some of the details about the WaveLight Plus there. So you're all invited to come.
Thank you very much, everyone, and thank you to my panelists, speakers, and co-moderators. Thank you.